கொஞ்சம் சார் பிஸியா இருந்தீங்க. ஓகே, ஸ்டார்ட் பண்ணிடலாமா சார்?
Yeah, we can go ahead. I think we can start.
Yeah, okay. Greetings to everybody who has joined with us today for yet another interesting session on Pediatric Dialogues with National Experts. So this has been a part of our national endeavor under the Presidential Action Plan to bring the expert opinion from all over India. And we have several interesting sessions, and we have had quite a number of national experts been joining us. And today it's also very knowledgeable two experts have joined with us for a very interesting session on shock in PICU. So as we go ahead, let us first start off with the pediatrician prayer. I request Dr. Thirumurugan Sarin, the academic coordinator, to start the session with the pediatrician's prayer.
Thank you very much, Dr. Narmada. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love, and peace to all children and their families, irrespective of the status and creed. Give us the wisdom, understanding to change the things we can, retain the good, and accept within reason the things which
Dr. Dr. Hello. Can anyone hear me?
We can hear you.
Yes,
Yeah,
yes,
so I think
yes,
Dr.
yes,
Thirumurugan
yes.
is stuck. Yeah. Okay.
Your voice is breaking.
Breaking.
Video off and the bell.
I think he has gone off
Okay.
the line, sir.
Yeah.
Okay.
You proceed.
Okay. Yeah,
prayer
sure.
முடிச்சிட்டு அப்படியே start
Yeah, start
yeah.
panel. Today, the weekend has been exciting with two of our, we had the sports and cultural competition of IAP Tamil Nadu State Chapter, Sports Culticon 2025. It just ended at around 4:30 today. And as our president and all the office members were in that. That's why our president is not able to join. So instead, I request Dr. Singaravelu, sir, to give the welcome address and invite all the delegates on this platform and off the platform.
Thank you, Dr. Narmada. Good evening to all. The most respected, our senior Professor Dr. Srinivasan, and our president in absentia, Dr. Rajendra, he is a PICU consultant and specialist, madam, and he is on the way. His signal is poor, but he will be joining shortly. Our dynamic secretary, Dr. Narmada, and our academic coordinator, Thirumurugan, and all the professors and academician faculties of our Tamil Nadu has joined in large. More than 25 faculty has joined, and other members who have joined in YouTube. And today it is a very happy day for me, in the sense that the two young dynamic, I can say, two professors whom I met within a week's time, who readily accepted in a very short notice. That too, Professor Lakshmi Subhava, a very active, dynamic, not only in academics, as a PICU consultant for more than 18 years, experience in the PICU, especially in Bhai Jarabai Wadi Children Hospital. Wadia Children Hospital, as you know, Mumbai, one of the very prestigious institution among India and also internationally. And she is heading the PICU department, and she held a various position there. The day I met her, the amount of response she gave as a Tamilian, we are really honored and humble, madam. That shows the spirit of our academician. Since I introduced myself as a professor, the way she took me to all her people cannot be forgotten. It is a laudable. Thank you for accepting, madam, for our invitation within a very short notice. Thank you. We are welcoming you on behalf of our IAP TNSC, which consists of 4,200 members with the great academic activities, madam, and 68 medical colleges, and most of the postgraduates will be joining today, madam. And to add to that, very young dynamic Daisy ma'am. to whom I had a chance to be as a panelist, so where she was moderating the session in the last Sunday. You all know that I am extensively traveling and I didn't have time. But what she prepared my topic and gave to me. She made our job and did this panel at Jaipur, which was a very wonderful event. We could have a good science at Jaipur because of JC ma'am, who is a professor and in charge of PICU, in of the very prestigious institution. I can say the first aims other than Delhi, which was formed, I think it is Jodhpur. I again had the opportunity to visit that institution where the infrastructure and the amount of work they are doing is really great in Jodhpur, and Madam is heading. And if I start talking both of them, I'll be talking about their academic credential, and I'll be wasting their time because people are here to listen academics. But we have two great stalwarts who are trained and dedicated and actively practicing in a very prestigious institution as one is Wadia Children Hospital, Mumbai, I think, which is one of the best government institute which can see where I have visited many colleges. Second, I have gone to many apes of which I could really wonder the amount of workload in Jodhpur they are having. That too, Daisy ma'am unit I could visit where our Jagdish and our Neeraj both took me to all around they showed. So really it was a very thing. I welcome on all of you. Thank you. Without wasting much time, I hand out to Namada to introduce the topic and to proceed further.
Thank you so much, sir. Thank you for your very kind introduction and your felicitations. As we move on to the session directly, as many of us are waiting to eagerly waiting to hear the lectures by the experts, I hand it over to the academic coordinator, Dr. Thirumurugan, to introduce the speakers and start the session. Over to you, sir.
Thank you. Thank you.
Sir, we can switch off your video because sometimes your voice gets broken off.
Yeah, I know. I think I have a problem. Sorry.
Yeah.
Yeah. I mean, we are. Ma'am, do you want to share your slides?
Yes, sure. I'll share.
Dr. Daisy Kera madam will be giving her first
Sure.
lecture.
I'll share.
Yeah.
I think they're just going to. I think this Dr. Singarodu sir has already introduced them. So without wasting much time, I request both the expert speakers to proceed with the talk. Thank you, sir.
Okay, thank you.
A very good
Daisy, you're muted.
A very good evening to all of you. At the outside, I would like to thank the organizers of the IAP's Tamil Nadu State Chapter, especially Singavelu sir, for giving us this opportunity. Myself, Dr. Daisy Khera and Dr. Lakshmi Shobhavat, we all thank you a lot. And beginning with the session for today, that is shock identification and management. So we chose this topic because we as not only intensivists but as general pediatricians also, identification of shock, which is a life-threatening condition, is very important. So prompt identification and correct management can be extremely life-saving for tiny tots. So let us begin with this presentation. So the outline would be to understand the mechanism of impaired tissue oxygen delivery, recognize early symptoms and signs of shock so that prompt management can be instituted as early as possible, differentiate between compensated and hypotensive shock, identification of septic shock, and to go through its management, overview of cardiogenic, distributive, and obstructive shock.
So when we talk about shock, what do we understand by that word? We understand that there is a mismatch between the supply of oxygen to the patient's tissues and the demand of oxygen by the body. Am I not audible?
Yeah, you are. You are audible.
Okay. No, there was a message which said not audible. Sorry. So when we have this mismatch happening in the body, what are the mechanisms mechanisms by which the body will counteract this imbalance. The body has its own innate sense, and it starts to work in its fashion, and we will recognize the same things, like it will increase the heart rate. Okay, by increasing the heart rate, it will increase its cardiac output. It closes down the peripheral circulation. It says that it's not interested in giving blood supply to the nails and the tiptoes and the tip of the nose. It is more interested in giving circulation to the brain, to the heart, to the liver. These are the organs from where the blood is diverted from the tissue peripheries. So you will have cold extremities. Okay, you have the blood pressure is tried to keep above the 5th percentile, and then eventually you have, because you have shunted the blood from the splanchnic circulation and the kidneys also, then you may have a decreased urine output. So when you have a patient in shock, your body has already started acting, has already started recognizing it, and has started the compensatory mechanisms. Next slide,
So,
please.
yeah. So to treat shock, we must understand the physiology of shock. So we have, this is a very important terminology called oxygen delivery, which is denoted by DO2. Just a minute. Yeah. So if you talk about DO2, we have, DO2, that is oxygen delivery, is determined by two important components, cardiac output and arterial oxygen concentration. We all know that cardiac output is a product of stroke volume and heart rate. And stroke volume in turn is determined by three important factors: preload, afterload, and contractility. So by increasing venous return, we can increase the preload. Afterload also, which is denoted by, afterload is denoted by mean arterial pressure and systemic vascular resistance. And contractility, if you have a poor contractility, your cardiac output will be less. So by use of inotropic agents, we can increase the contractility. But not only cardiac output, but the arterial oxygen concentration also determines your tissue delivery of oxygen. So what does the CaO2, that is the arterial oxygen concentration, depend on? Hemoglobin as well as oxygen saturation. As you can see in this formula, hemoglobin into 1.34 into saturation. So we should understand that 1 gram of hemoglobin carries 1.34 ml of oxygen. So the oxygen in body, in blood, is carried in two forms. This is the bound oxygen, the oxygen bound to hemoglobin, and this is the dissolved oxygen in plasma. And 0.003 is the solubility coefficient. So whenever we have a child with shock, we need to increase his arterial oxygen concentration by optimizing his hemoglobin, by increasing his oxygen saturation. How can we increase the oxygen saturation? By giving him high flow oxygen. So any child in shock, even if your saturations are normal, you need to give him oxygen by high flow, that is NRBM or HFNC. And you have to optimize the hemoglobin, keep it more than 10. And of course, use of agents, vasoactive agents, that is to increase the preload, fluid resuscitation to increase the preload, inotropic agents to improve the contractility. So this physiology is very important to understand how to manage shock. So when we talk of the resuscitation of shock, there are certain upstream markers and certain downstream markers. So upstream markers are the very obvious endpoints of resuscitation, like your preload. How do you measure your preload? By the CVP, that is central venous pressure. However, one value of central venous pressure is not important. It is the trends of CVP that is important. Your mean arterial pressure and SVR, your stroke volume that you can calculate by use of echocardiography, your heart rate, your blood pressure. And as we discussed, the DO2 parameters, the partial pressure of oxygen, the hemoglobin, and of course the cardiac output. But other than these upstream markers, we have some downstream markers which are very important. Among the downstream markers, SCVO2 or the SVO2, this is the mixed venous saturation. This is ideally measured in the pulmonary artery. But pulmonary artery catheter is an invasive procedure. So what we do bedside is SCVO2. So SCVO2 means central venous oxygen saturation. How do we measure it? If we put a central line in the internal jugular or the subclavian, whatever saturation we are getting in that venous blood gives us what is the central venous oxygen saturation. And the target is to keep it more than 70%. To just simplify, whatever oxygen delivery is occurring at the tissue level, there is extraction of oxygen. So 25 to 30% of the oxygen from the blood is extracted by the tissues. So what is remaining reaches the right side of the heart. So 70% is around 70 to 75% should be reaching the right side of the heart. So this is what SCVO2 is the balance between the oxygen consumption, oxygen delivery and the oxygen consumption. So that is why the target of SCVO2 of more than 70% that is desirable. And lactate, as we all know, is a very important measurement of tissue perfusion. So lactate values more than 2, or as the Phoenix sepsis criteria says, more than 5. That is an important, hemodynamic monitoring tool and very easily available in blood gases. Rest, the PCO2 gap or the arterial venous CO2 gradient, which also gives you an idea of tissue oxygen tissue delivery, base deficit, pH. But among all these downstream markers, as said, mixed venous saturation or the central venous oxygen saturation and lactate are the most important.
We missed one slide. Can you go back up where that?
Yeah.
Yeah.
Yes.
So
Yes.
the oxygen delivery to the tissues, therefore, depends upon hemoglobin being able to carry all the oxygen. So if you have a patient with low hemoglobin, your shock will not be easily corrected. So you have to look at optimizing that. Okay. Now, if you have a saturation in SpO2 which is not going up, then again you will face a problem in delivery of oxygen to the tissues. So there may be an early indication of a positive pressure, or like Dr. Daisy said, giving high flow oxygen. But sometimes only high flow oxygen may not suffice. If you have a necrotizing pneumonia who's gone into shock, then the pneumonia may be so severe that you may not be able to reach a good saturation and you may need positive pressure in this patient. Okay. We also know that in pediatrics, the heart muscle is very small. The pediatric heart itself is a small organ, and hence it relies on heart rate, to bring out its cardiac output. So heart rate is a very sensitive indicator in pediatrics for identification of shock as well as for monitoring the patient, because it does indicate resolution of shock. Daisy, can we go to the clinical features, please?
Yeah.
Yeah, so clinical features, therefore, for shock are tachycardia, which is in absence of fever or disproportionate to the amount of fever that you have. You have a prolonged or a flash CRT. A prolonged CRT is anything more than 3 seconds, 2 to 3, more than 2 seconds, and a flash CRT is something which just comes up within a second, less than a second, where it means a vasodilatory state. Okay, diminished or bounding peripheral pulses, a mottled cool extremity, altered mental status, and finally a decreased urine output. So always remember to ask for urine output in the patient. Yeah. Now, once you know that there is shock, you have to go ahead and classify it on severity, that whether it is compensated shock or whether it is hypotensive shock. Hypotension is defined as anything which is in a 1 year old till a 10-year-old, anything which is 70 plus 2 into age in years. Okay. So if you have a 10-year-old and you have a 90, less than a 90 in the systolic blood pressure, then it is hypotension for that child. Okay, this is a very easily remembered bedside number, which I think everybody should learn: 70 plus 2 into age. So if it is not hypotensive, then and the features of shock are present, then we will call it compensated shock. Now, once you have done this, you've categorized it on severity basis, you also need to start thinking on what is the cause of the shock. Okay, so what are the possible um, divisions in which we can divide shock into? First thing is where we know that the pump, that is, the pump is failing. Okay, so pump yani yahan par it is the heart, so it could be a cardiogenic shock. Okay, so cardiogenic causes, there are multiple causes for cardiogenic in pediatric. Um, it could be a cardiomyopathy, it could be myocarditis. Okay, then it could be the tank, that is the pre-fill status of the patient. So where do you have losses from the tank? Like you have a acute gastroenteritis where you have vomiting and diarrhea, and you are losing volume. You have a patient with hemorrhagic shock and you're losing volume. So that is the hypovolemic variety. Okay. Then the pipes meaning the pipes are leaky. There are multiple holes in them. So where does that happen? That happens most often in septic shock, where you start losing the fluid. You also start losing fluid in dilated states in neurogenic shock as well as in anaphylactic shock. Okay, now dengue is also in a way a dysfunction of the pipes where you start leaking. This is this phase we are seeing a lot of dengue in Mumbai. So we are losing a lot of fluid from the pipes. And finally is the flow, where if there is an obstruction to the flow, there is a sudden outflow obstruction, then it may be a tension pneumothorax or it may be a cardiac tamponade, which is causing obstruction to the flow. Okay.
So now we know the four major types of shock, the causes of shock, but we can also categorize shock based on the pathophysiology. So we have heard the terms cold shock, warm shock, but there was a beautiful paper by in which Dr. Suchitra Ranjit Madam was also a co-author, in which they found that the clinically, if you have a cold shock, but if you do a multimodal hemodynamic monitoring, you measure cardiac output and SVRI, in a cold shock, clinical cold shock, you may still have a SVRI that is low and vice versa. So it is better to actually label shock as vasodilatory or vasoconstrictive. So let us see, based on pathophysiology, in hypovolemic and hemorrhagic shock, you have increased losses. So you have a compensatory mechanism of high SVR to maintain the cardiac output. So what you need to do in hypovolemic or hemorrhagic shock is volume replacement, either with isotonic fluid if it is a hypovolemic shock, or if it's a hemorrhagic shock, after one bolus, as the ATLS guidelines will say, you have to give blood, and a massive blood transfusion protocol may need to be activated. Coming to the distributive shock, septic shock, anaphylactic shock, and neurogenic shock. So here we know we have low SVRI. Septic shock is a status of vasoplegia because of the inflammatory mediators. Anaphylactic shock, again, because of histamine, you have vasoplegia, vasodilation. Neurogenic shock because of the loss of sympathetic tone. So all these result in low SVR, but a normal cardiac output. So what you need to do is, however, you can also have a decreased cardiac output. If you have a less preload, then what you need to do is give vasopressors and noradrenaline, vasopressor, and sometimes adrenaline if your blood pressures are too low. Coming to cardiogenic and obstructive shock, we have, last slide, as Dr. Lakshmi elaborated, you have this pump failure. So what you need to do, need to give inotropes because you have a decreased cardiac output. Your SVR can be normal or increased. So you need to give inotropes in the form of adrenaline or inodilators, dobutamine and milrinone. However, many times we have seen that once we start dobutamine or milrinone, the blood pressure may crash. So at that time, we need to, optimize and start adrenaline. So you might continue dobutamine milrinone with some doses of adrenaline, or you might need to stop it. Coming to septic shock, we have seen septic shock is a kind of distributive shock in which there is vasoplegia. However, there is also relative hypovolemia. Also, it can occur as SIMD, that is sepsis-induced myocardial dysfunction. That is why in septic shock, you need volume replacement to overcome the relative hypovolemia. You need to give noradrenaline as a vasopressor, and you might need inotropes as well for sepsis-induced myocardial dysfunction. But majorly, septic shock is characterized by low SVR and decreased cardiac, and sometimes you can have a decreased cardiac output. Now, not all shock. It has been seen that only 50% of the shock patients are actually fluid responsive. So fluid responsive means a response to fluid challenge by improvement in stroke volume by at least 10%. So this is the Frank-Starling curve, which we are all aware of. So you have to judge where your patient lies in this Frank-Starling curve. If the patient lies in this part, so he will be, responsive to fluid, because by giving preload, if you give a fluid resuscitation, you'll increase the preload, you'll have stretch of myocardial fibers, and your stroke volume will increase. However, if he lies in this part of the curve, by giving more fluids, still your stroke volume will not increase. And we know that after 1 hour of administering fluids, fluid creep occurs. Fluid goes from the intravascular to the extravascular into the interstitium. It will cause pulmonary edema, causing respiratory failure. It will cause multi-organ dysfunction, renal failure, liver failure, intestinal bowel, edema. So nowadays in intensive care, there's a term less is more. So we are more and more coming to fluid, restrictive strategy. Earlier we were giving more and more of fluids, but now you have to assess if your patient is fluid responsive or not. So after each bolus, you need to assess whether he's responding to fluids. If his heart rate is decreasing, his blood pressure is increasing, he's fluid responsive, but you have to see for signs of fluid overload after every bolus. See for hepatomegaly, see for Krebs. If previously Krebs was not there, it has come. Previously liver was not palpable, it is palpable. So clinically he's going into fluid overload. Don't give any more boluses. And if you have focus, that is point of care ultrasound, you can see your IVC. If it has become distended, you see for lung ultrasound, if you can see B lines which are previously not there, they are all indicative of fluid overload. So give your fluid judiciously and assess if patient is fluid responsive or not. So coming to cases, so we have a case of Master Anil, a 2-year-old boy who presented with the 3-day history of watery stools and vomiting. So initial impression on this PAT triangle, he was lethargic, he was pale, he was tachypnic. So we see all 3 systems are affected, and definitely there is respiratory and cardiovascular insufficiency. So what do you do? You gather your team, start oxygen, attach monitors. So coming to the primary assessment pentagon, his airway was open, his breathing was normal, saturation was 94% on room air. He was having sinus tachycardia, central pulses and peripheral pulses were feeble, CFT was more than 4 seconds, blood pressure 78/54. So as Dr. Lakshmi very well elaborated, do you think this child has hypotension? So he has a blood pressure of 78. As she said, 70 plus age into 2. This is a 2-year-old child. So 74 plus systolic blood pressure means there is no hypotension. So this is not hypotension, but is it shock? Yes, this is shock because you have central pulses, peripheral pulses, fever, and a prolonged CFT. So disability exposure wise, he was normal. So we label him as compensated shock. And what do? Intervention. We start oxygen by non-rebreathing mask because we need to give high flow oxygen. For his compensated shock, we put a IV access. If we fail IV access in 3 attempts or 90 seconds, we need to put a IO access intraosseous. Check his calcium, RBS. You can take culture and CBC electrolytes. Start NS and RL bolus 10 to 20 ml per kg. Now, literature, the evidence still in favor of 10 or 20 is debatable. However, if you have definite volume loss, you have a diarrhea, a history of many episodes of loose stools or many episodes of vomiting or hemorrhagic shock, you can give bolus of 20 ml per kg. So here what we did, we took a sample history in which we got history of watery loose stools and vomiting for past 3 days. So we identified it as volume loss or hypovolemic shock. We continued the fluid bolus 20 ml per kg over 15 to 20 minutes. Again, boluses over 15 to 20 minutes or 5 to 10 minutes. So if you have a hypotensive shock and a definite hypovolemic or hemorrhagic shock, you can give by push or pull technique. Otherwise, 15 to 20 minutes is the dictum to give fluid bolus. After 1 bolus, as I said, assess. If you have signs of volume overload, do not give more boluses. If you do not have signs of overload and still the shock persists, you can give another bolus up to 60 ml per kg in hypovolemic shock. But provided ICU backup facilities are available. If people working in PHC or CHC where there are no ICU backup facilities, do not give fluid more than 40 ml per kg, as advised by surviving sepsis guidelines. You did a focused examination, you found signs of dehydration, there was no gallop, no hepatomegaly, and severe dehydration, so we'll give severe dehydration correction. We saw IVC in this chart, and we saw IVC collapsibility. More than 50% means you need to give fluids. You can see here IVC was collapsible, and So we labeled him as hypovolemic shock with acute gastroenteritis with severe dehydration, and this is how we manage this patient. So how do we know the shock has resolved? So there are some therapeutic endpoints, and all of them should be met to say that shock has resolved. You should have your distal pulses, that is peripheral pulses, equal to central pulses. You should have warm extremities with CFT less than 2 seconds or equal to 2 seconds. Normal mental status, urine output should be more than equal to 1 ml per kg per hour. Heart rate should be normal for appropriate for age. Systolic blood pressure should be at least 5th percentile for age. Your cardiac index should be normal, that is 3.3 to 6 liter per minute per meter square. Wherever POCUS is available, we will suggest all our postgraduate students to actually start doing bedside ultrasound. It has a short learning curve. It is not difficult to see IVC or do lung ultrasound, and even calculate what is the cardiac output based on your stroke volume. You have to measure the serum lactate. It should be less than 2 millimole per liter, and SCVO2, as I mentioned, the central venous oxygen venous saturation should be more than equal to 70%. So another case, a 3-month-old baby, exclusively breastfed, was brought with a 1-day history of URI, poor feeding, and breathing difficulty. Child was well previously. So he was irritable, pale, tachypnic. So we identified him as unstable. He has respiratory and cardiovascular insufficiency. So I think if we can make it interactive, I will ask this case, and anyone can unmute and answer if they wish. So what do you do now? Intervention, you gather the team, start oxygen, attach monitors. So on primary assessment, we have an airway that is open, maintainable. What do we see in breathing? There is definite respiratory distress, there is grunting, bilateral reps, and saturation is 89% in room air. Circulation-wise, he has a sinus tachycardia, but central pulses are good, but peripheral pulses are feeble. CFT is more than 4 seconds. Blood pressure is 80/60. So what do you think? Can anyone please unmute and answer? Do you think this is hypotensive shock or this is compensated shock? Yes, anyone? Is it this is a 3-month-old child. So his systolic blood pressure is 80. Is it hypotension? So Dr. Lakshmi, can you see in chat box if someone can just type when we ask? It will be good to have some interaction. So this is not hypotension, because the systolic blood pressure for an infant should be more than 70. So a neonate should have a systolic blood pressure of more than 60, and infant
You
more
have
than.
answers for compensated.
Okay, right.
They answered, madam. They answered.
Right, correctly. So this is compensated shock. In an infant, a systolic blood pressure more than 70 is appropriate for him. And so this is compensated shock. He was irritable. His temperature was normal. So what do you think is the physiological classification? Anyone? Can you please type in the chat box? Physiological classification? Respiratory failure, as we see, saturation is less than 90% in room air, and compensated shock. So he has respiratory failure with compensated shock. So what do? Again, we give high flow oxygen by heated humidified high flow nasal cannula or CPAP. What do we do about the compensated shocks? We put a IV or a IO axis, check for calcium. You can do a in blood gas, you can see sugars, or you can do a capillary blood glucose. Start NS or RL bolus, again 10 to 20 ml per kg. What would you start in this child, 10 or 20? You have poor feeding, but you don't have diarrhea, vomiting, so you might as well start with 10 ml per kg. So coming to secondary assessment, sample history, we reviewed again the history. He had URI, that is upper respiratory tract infection, for 1 day, no losses, no fever, breathing difficulty. There is no volume loss. Sepsis is unlikely, as child has no fever, nor does he have hypothermia. We should understand that in infants, even hypothermia is a sign of SIRS, that is systemic inflammatory response syndrome, but he did not have hypothermia also. So we decreased the bolus to 10 ml per kg because we did not think he has volume loss or sepsis. Focused examination, we found hepatomegaly, gallop rhythm, heart sounds were muffled. So this, raised our ears. There was features of cardiogenic shock and pulmonary edema. So we stopped bolus and we started him on inotropes. and restricted fluids. So many a times, in emergency, if we just recognize shock and we give a bolus 20 ml per kg, not responding another 20, and we fail to, see for hepatomegaly, see for, how is the heart sounds, gallop rhythm is there or not. So we will, if we, in cardiogenic shock, if you give what is recommended in cardiogenic shock, you can give up to 5 to 10 ml per kg. If you give more boluses, you can actually land up in, respiratory failure and intubating the child and bad prognosis. So this was his X-ray. We can see cardiomegaly and features of pulmonary edema. This was his echocardiography. You can see here the left ventricle is dilated and contractility is not good. So if you calculate the ejection fraction was low in this child. We can see we did the ultrasound. If you see for IVC, you can see the distended IVC. You can see the distended hepatic vein as well. And we saw the lung ultrasound in this child. And if you can appreciate, I don't know how many of you do, I think in postgraduate these days, they must be doing, and pediatric intensivists, of course, do lung ultrasound. So you can see confluent B lines. B lines are the comet-shaped lines which extend from the pleural line down to the screen. Usually, they are less than 3, but you have more than 3. And confluent B lines, like you can see in this child, and which is clearly visible in this image, you can see confluent V line. So it is suggestive of pulmonary edema and no more boluses to be given. So we labeled this child as acute myocarditis with cardiogenic shock. And other than the inotropic agents, you need to see what is the calcium. If you need to correct that. This child had low calcium. Correction of anemia is important. Once shock stabilizes, you need to put him on diuretics. So cardiogenic shock, as we know, the etiology, congenital heart diseases, the left to right shunts more commonly, the inflammatory diseases, viral myocarditis is very common. Other than that, in children, you can have Kawasaki disease and MISC. Dysrhythmias are common in infants. PSVT commonly occurs in results in cardiac failure and even shock. Obstructive lesions, sepsis, as I said, sepsis-induced myocardial dysfunction, envenomation trauma can also be causes of cardiogenic shock. And if you see in cardiogenic shock, systolic dysfunction is more common than diastolic dysfunction. So in cardiogenic shock, you need to prepare for intubation. How does ventilation help the failing heart? One, it minimizes demand because it decreases the oxygen demand, the oxygen requirement of the heart itself. Therefore, it will, and also by giving rest to the respiratory muscles, the oxygen consumption will decrease. So, and the oxygen for the major organs will be more. And it also maximizes function. You can, sedate the child, then be tachycardia control. You're giving rest to the respiratory muscles. If you have left ventricular failure, as you know, positive pressure ventilation will decrease the preload. It will also decrease the left ventricular afterload. So it is good, especially for left ventricular failures. So now for case 3, over to Dr. Lakshmi.
Well done. All the 2 cases were really interesting. Let's go on to the third case. It's a very simple case. A 1 year, 8-month-old known case of infantile onset nephrotic syndrome who's come with loose stools to the hospital.
Sorry.
Yeah. That's okay. Yeah. Okay. There was one more slide, I think, before this. Just go back. There's nothing there? Okay, fine. So on assessment, we find that the slides are moving very fast. The airway is
Yeah.
open. The child is breathing with fast respiratory rate of 50 per minute, and there is decreased air entry on the right side. The saturation is 94% on room air and quickly comes up to 96% when low flow nasal oxygen has been started. Okay. Circulation wise, heart rate is 180. The CRT is less than flash CRT. BP is 82 by 34 with a mean of 36. The peripheral pulses are bounding. The child is warm and there is not passed urine for the last 8 hours. Okay. The child is irritable, has a verbal response, cries out to the mother. Okay, pupils are reacting. She does have a temperature and there's some redness on the abdomen. Now, how would you like to classify this child? Would we say there is respiratory distress over here? And we can say shock, or yes, we will say shock. Okay, and we will say possibility of what is the, yeah, next slide, please. So he's a nephrotic, is having diarrhea, has features of shock definitely. What is the severity of shock? Here we've called it compensated because the systolic blood pressure was way above the 70 plus 2 into age. And what is the etiology of shock? Can it be hypovolemic because the history said lot of diarrhea and loose motions were going on? I can see somebody has responded as septic. Yes, possibly more septic because there is bounding pulses and there is also a suspicion of sepsis. Okay, okay. The abdomen. There was a picture of the abdomen somewhere.
Yeah, it will come.
Compensated septic shock. Yeah. Okay. So sepsis with respiratory distress. Whether there is a parenchymal association, whether there's a parenchymal involvement, we'll see. Let's go. So what are the next steps when you suspect septic shock? So when you start suspecting septic shock, first and foremost is to confirm your sepsis and shock. So you can send for to confirm shock, you can send in your ABG, look at the lactate. Whenever you start thinking sepsis, send a blood culture and also give an antibiotic, at least a broad spectrum antibiotic. Okay, and search for the focus of sepsis. Okay, that would be the thing. See, now look at this tummy. You can see the redness here. So there's definite cellulitis. Whether there is peritonitis, we'll have to see. Okay, so sepsis is a life-threatening organ dysfunction by a dysregulated host response to infection. Now, in this particular case, the host response we know will be a problem because it's a nephrotic child. Okay, septic shock is when you have cardiovascular dysfunction. You may have hypotension, you may have need for vasoactive medications, and you have impaired perfusion. So, in this child, what are the signs of impaired perfusion? Okay, you have those bounding pulses and you also have decreased urine output. Okay, go on. When do you suspect sepsis? Now, this is a very common thing in pediatric. I think all emergency rooms should have this. That to know it could be a child with fever, with cold, with rapid breathing, with pale or mottled skin, who may be disoriented or may not be getting up and have an elevated heart rate. All these scenarios, they're very, very common. If you just think about it, you'll see them every day in your ER. But every patient could be a patient of sepsis there. Okay, so you should start suspecting sepsis much earlier. So this child was on ABG. We put him on an NRM and pH was 7.13 with a low bicarb, with a PF of 190 and a high lactate. And bedside POCUS was done, which showed hypercontractile left ventricle. Go on. And there was an outside investigation which showed a little no hemoglobin with high count with a polypredominance, and there was an INR also, with a low platelet and a high INR, suggesting bacterial infection with some DIC possibly over there, and a high renal BUN with a high creatinine. So there was multi-organ dysfunction that was evident along with this. So how do we use this? How do we interpret? Is there any score? There is this Phoenix score where you know that a SF ratio, okay, less than 292 on any respiratory support, or a PF ratio of less than 400 on any respiratory support. So that is 1 point for this patient. Platelets were 48, so that's another 1 point here, and a INR which was high, again another point. She was yeah, nearing 2 year old, so 32 her respiratory mean arterial pressure was low. Okay, that's another 4 points. 5 lactate was high. Yeah, so when you have a high score, Anything which is score more than sepsis score is more than, if you have more than 2 points, and if you have anything with a cardiovascular point here. See, can you see this? This is the cardiovascular point. Thank you. So when you have a cardiovascular point here, that means that you have septic shock. So this is a reckoner which can be placed in your casualties, in your ERs, to pick up the patient. The only thing is there are a lot of labs which are needed, which may not be immediately and emergently available to you at the bedside, like INR. I'm sure an INR takes an hour or an hour and a half to get done at least. Please go on. Next slide. So how do you manage? You give the patient oxygen. You can use NRM oxygen. The child need IV fluid. Will boluses? Yes, definitely we'll need a bolus. How much to give now? It's a nephrotic child. So you will begin with 10 cc per kg over 20 to 30 minutes. There was a response of the heart. Heart rate came down from that 180 to 170 and then a 160, but it kind of was staying on 160. So at this point, we decided we needed a 2D echo. We gave the child noradrenaline. Okay, we were debating, there was a little debate on using albumin at this time, because the child has low albumin but has renal failure. So it is a double-edged sword here. You may sometimes manage it, or many times you may push the child into a pulmonary edema. Okay, so we'll need early ventilation there. An antibiotic was added, cloxacillin, and a ascitic tap was done for looking for SBP. The fluid which came out was really yucky, mucky fluid which came out, and this is a good way of getting out some source control also. So in sepsis, when you have a focus, and if you can decrease the sepsis focus, and source control helps the patient also recover. So it was a good idea to do that. So in sepsis, it is a time planned methodology of working. So surviving sepsis guidelines says that first, as soon as you recognize your severe septic shock, you will start oxygen by non-rebreathing mask oxygen, get in your IV IO access really quickly, and send in your at least your ABG and a lactate, and do a RBS at the blood side. Okay, if you have a hypotensive shock, in the next 5-10 minutes, you would give in a fluid bolus. Maybe you'd give in a 10 cc per kg at least in the next 10 minutes in a push pull thing, and then maybe the next bolus can go in a little slowly. First dose of antibiotics, and watch again, reassess your patient. Okay. Now next what happens is, now is the shock resolved or not resolved? The shock is not resolved. You will put there are no signs of fluid overload, means there is no crepitations and there is no liver which has come up. You may repeat your boluses. You may go up to 40 to 60 ml of per kg of fluids. Okay, if there are signs of fluid overload, you may not be able to use your fluids. You will need some other kind of methods, like you may use an inotrope or a vasopressor. Can we go next? Once you have no response to fluids, the shock is persisting, you will call it fluid refractory shock. And in fluid refractory shock, what are the things that you have to rule out? You have to rule out if there is a obstructive system. Okay, remember that picture that I showed you? So if there's an obstructive system, so there is a pneumothorax or a cardiac tamponade, you need to rule that out. Okay, then if you see if it's a warm shock where you have bounding pulses and you have a diastolic wide pulse pressure, in that situation you can start with noradrenaline. If you have a cold shock, these are clinical, like Dr. Daisy said, there is newer data to suggest that what we perceive as cold shock may not really be all cold shock. Hence, filhal, because that's the only thing right now, unless you have multimodal monitoring, this is the only way to go about it. So you will use your hands and your assessment of blood pressure and start the patient on adrenaline. Okay. In this patient also, as this child was a nephrotic, we will expect that the child was having HPA axis suppression, and therefore we will give him the hydrocortisone much earlier. Okay, so hydrocort and stress doses 100 mg per meter square or 50 mg per meter square is warranted here. Okay. Cardiac dysfunction, if you've done your focus and you can see that the Dr. Daisy showed you a heart which was not contracting. Sepsis can also cause myocardial depression and myocardial dysfunction, and you can add dobutamine to this patient, but after you have a decent systolic, not at a low systolic, because then you will drop your blood pressures further. Okay. You will target a map and therapeutic goals are not met, then you will call it refractory catecholamine refractory shock, and then you may consider ECMO or transfer to an ECMO center if you're not an ECMO center yourself. Okay. Septic shock, usually there is a focus. You just have to sometimes look very closely for it. This is just a picture of an immunocompromised. He's a post BMT child who had high fever, and you know how in BMT, post BMT status, we're even worried about the smallest of viruses, smallest of bacteria, or even a commensal may be a problem, and you're treating everything possible. And this child had actually a dental pulp abscess which went unrecognized for almost 2 days before we actually saw what was happening to him. Okay, so open the mouth, look at every possible focus in the patient. Okay. Okay, a 2-year-old boy was brought to the emergency after a fall from a height. This is their last case for the day. While playing, and he was initially, the parents saw him cry, but when he came to the casualty, he's drowsy and he's pale. Okay, so his airway though is open at present. There is some mild secretions which they have suctioned out. Uh, he is breathing at 50 per minute. There is increased efforts of breathing. There is a shift of the trachea to the left side, and there is absent air entry on the right side, and the saturations are 85% on mask. Okay, so there is a big problem happening over here. Along with that, what do we see? We see that when the monitor is connected, you see that its a heart rate is 172. It is sinus, and there is a CRT which is delayed, a BP which is 60/35. Now this was a 2-year-old, so a BP of 60. Nobody should have a BP of 60. It's 70 plus 2 into age after 1 year. So it is definitely hypotension here. No thinking over there. And skin temperature is cold, and his neck veins are looking distended. Okay, what are we thinking in this patient? Let's go ahead and finish our things. And GCS is uh, GCS is E2V2M4, drowsy. Pupils are reacting to light, and RBS is 106. Okay, on exposure, the child has normal temperature, but he has some bruising which we notice on the right side of the chest. Obviously, he's had a fall. Okay, there are no obvious broken bones that we can see. That is the next important thing in this patient. While we are doing all this, we will always put a cervical collar in this patient. Cervical collar को stabilize करना जरूरी है. Okay, let's go आगे. Yeah, so our diagnosis here is cardiorespiratory failure because of a possible, what is it? There is no air entry and there is hypotension, so we will call it probably a shock situation because of a
We can
pneumothorax, a
cancel
right-sided pneumothorax. There was a hyper-resonant percussion, yes. So there is a tension pneumothorax. A tension pneumothorax is something which is a respiratory problem which is causing a circulatory compromise. Okay, it is causing an obstructive shock. Can we go ahead, please? How do we manage? We've already done the high flow. So let's get in large bore IV and accesses, because this patient is in hypotension. He will not give you any more time. You have to get those bells ringing, and you need to work fast in this patient. Get in your fluid, get in your boluses. Okay, do an urgent needle decompression in the second intercostal space, mid-clavicular line. Look for bubbling and follow it up with a chest tube. Okay, that is his x-ray there. Can you see he actually later on also, this is the most obvious one, but if you look subtly, there is also a small pneumo which came up in the next subsequent x-rays, because it was very small here. You can see the pneumomediastinum in this. Yeah. Okay, let's see what happens. happened to this child later. I think he was noticed to have an abnormal breathing pattern. Okay, now he did undergo a CT. He underwent something where we cleared off his spine, and then when we tried to when he was getting ventilated, also he had a seesaw type of breathing. So when a MRI was done, we noticed that he has signal changes in C1 and C2 area. So he had a cord injury, spinal cord injury. So this is a skivora which happened to this child, and he struggled a lot. He was very difficult because he wouldn't breathe on his own. He couldn't breathe on his own, and he was a difficult extubation. We never managed to extubate him. We kind of put him on a tracheostomy at some point. It was though the child was awake even after a fall, this was a catastrophic injury for the patient. Can we go ahead, please? Yeah, so it was not just mm, just a fall, and it was a polytrauma. He had injury. So in the polytrauma, you will ensure that you have an IV and IO access early. I need you to remember to do a cross match because that will save your patient. A cervical spine injury, yes, you need to stabilize your cervical spine. You need to do a CT head with upper cervical with the cervical spine, but not all cervical spine injuries are ruled out by CT scans. Okay.
Dr. Lakshmi?
Not audible, madam.
Yeah, so I'll
Her voice is.
continue. I think I'll continue until she comes back.
Yeah.
So we
Yes.
should
Yes. You
remember
continue.
you had the cause of shock as obstructive shock, but maybe you have treated for obstructive shock. You put a ICD, still your shock continues. So there could be a component of neurogenic shock as well in this because of the loss of sympathetic tone. So we'll need your vasopressors. And EFAST at the ER in any case of polytrauma to look for any evidence of bleed in the abdomen, look for pneumothorax, pericardial tamponade is very important. If EFAST is positive, he needs to be rushed to the OT. Obstructive shock is often accompanied by polytrauma. And remember, in hemorrhagic shock, after first bolus, we need to give blood as soon as possible. And now, for polytrauma, for your advanced trauma life support says, instead of ABCD approach, it is XABCD. If there is a exsanguinating, hemorrhage, you need to control that with pressure, bandage, ligation, and then proceed to ABCD. So, Dr. Lakshmi, I think you were lost for a few seconds.
Yeah, I had
I
lost connection.
completed this slide.
That's
So,
it.
we can come to the take-home message.
So, take home messages, shock needs careful assessment at bedside to pick up. Okay. You need to follow your ABCD approach. It adds a systematism to this assessment. Not doing one of the things, just in reacting to the respiratory rate, just reacting to desaturations may make you miss the circulatory component in the patient. So, remember to complete your ABCDE. Okay. That is what I mean by this. And once identified, quickly categorize them into compensated or hypertensive because the minute you diagnose hypertension, there isn't any time left. Okay, the body has already failed. Okay, it has already done whatever it could have done. So it's now up to you to save the patient's life. Simultaneously, possible etiology. So if it's sepsis, give your antibiotic. Obstructive, you need to treat the cause. Cardiogenic, think of low boluses, early inotropy, maybe early intubation even. Okay, anaphylactic, adrenaline injections, IM injections. These are the things which will help you treat your patient faster. Hmm. Daisy, are you doing this or I'm going through?
Yeah. So IV fluid and boluses up to 30 to 40 ml per kg. Surviving sepsis guideline says if you don't have a ICU facility, do not give bolus in compensated shock. Only in hypotensive shock, you may give bolus, and that too only up to 40 ml per kg if ICU facilities are not available. I think some of you must be knowing about the famous peace trial that was, RCT, which was conducted in African countries, and they found where no ICU facilities were available and boluses were given beyond 40 ml per kg, there was very high mortality. So based on that, our RCT, which was published in NEJM few years back, this recommendation was given. So injection adrenaline may be started if transporting a patient in undifferentiated shock. If we don't know the reason for shock, probably after 120 to 30 ml per kg of bolus, you should start an adrenaline and transfer him to a place where ICU facilities are available. Check blood sugar. Many of the times, hypoglycemia can cause cardiac dysfunction. Hypocalcemia can cause cardiac dysfunction. So treat your blood sugars, treat your hypocalcemias. It's look at your ABG to look for, or a venous blood gas to look for lactates, uh, 2D code. These days, we say the stethoscope of a pediatric intensive has been replaced by bedside ultrasound. So again, I would urge, it has a short learning curve. Learn to do even eyeballing of IVC and cardiac contractility, and lung ultrasound is quite easy. You can recognize the B lines. So it will help you decide if you want to give more boluses or not, and it can actually prevent catastrophe from happening. And ventilation for shock, not only for cardiogenic shock, for any shock. If if it's a you need catecholamine resistant shock, you need to put him on positive pressure ventilation, as it helps in the recovery of shock. So that's all. Thank you from both of us, and we are open to questions.
Thank you.
Thank you, ma'am. Both of you has done extremely well, and this is a very, I can stop sharing that.
Sure.
I think this is the most needed for not only intensives, for practitioners also, madam, where everybody has to know how to handle in an emergency, to come across whenever they come across a shock, and at least they should be able to extremely well. I'm happy that many professors joined. Ramakrishna Parameshwar sir, he has joined from Rajamundri, senior professor. Anybody, any questions? Parameshwar sir, Ramakrishna Parameshwar sir.
Good evening, sir. Good evening, all.
Welcome, sir.
It is really very good talks by both the speakers. They have done extremely well, really, as you said. And they are very clear, crisp, and their talk is informative. Right.
Thank you, sir. Thiru.
Yes, sir. Can you hear me? Sorry.
Our Somasundaram.
Sir, good evening, sir. Sorry for joining late.
Welcome, Somasundaram. He is the president of our major city branch, madam, and president-elect of future president of our Tamil Nadu state. And he is our coordinator for this program. Due to some personal commitment, in spite of that, he joined. Welcome, sir.
Thank you, sir. Thank you, sir. Thank you for your introduction, sir. So I was there for the past 30 minutes. I was hearing both madams, even though I am not into intensive care, and as you know, I am into child development and behavior. But even then, I too take care of pediatric patients, and both the talks were so informative. And the last one, the traumatic one, was nicely handled, and it was so informative, sir. And thank you, Singaravelu sir, for bringing two eminent speakers to our forum from AIMS and Vadia. So thank you very much for your informative talk, madam.
And a senior professor, great academician and former dean, Professor Ambuja madam also has joined. Madam Ambuja madam is a former dean and HOD and a very great academician. She has joined. Welcome, madam. Any comments from your side, madam? Ambuja madam? She is there. Okay. No. I think if there are no questions, once again from my side, madam, I am very much honored for both of you accepting in a very short notice. And really, we had a wonderful lecture today. Definitely, it is mainly meant for our postgraduate. Definitely, they may have been benefited because they could not interact much in a YouTube. But this lectures will be there in YouTube, madam, in our that. It will, in future, they can review, and it will be very useful to all our beginners, madam. If there are no further questions, Somsundar sir, you can give a concluding remarks and close the session.
Yes, sir. So as we are having this pediatric dialogues with the national faculties alternate month, so that this is the brainchild of our current president, Tamil Nadu State President, Dr. Rajendran sir, and you want to say something,
Sorry
sir?
to interrupt. So 1 minute.
Yeah.
Professor Mahadevan sir has joined. Mahadevan sir, any comments from your side? Professor Mahadevan sir, she has joined. From Jipper, but Mahadevan is a senior professor from Jipper.
Yes,
He has joined.
sir, we know him very well for his
You know
work
him.
on snake envenomation, scorpion envenomation. Yeah, we know him very well.
Yeah, he's joined. Sorry to interrupt, Doctor. I thought Mahadevan sir can give. Anyway, Somsam sir, continue, sir, please.
So this we are having it on an alternate basis, and we are getting the information and lot of knowledge sharing from eminent faculty from all over the country. So, and thank you, Sigaravel sir, since you are on a travel mode and you have reached many places in a quick time. You are able to pick up great faculty from all over the country, and we will be we and all of them will be with you for your future plans and your ambitions, sir. Thank you very much, and thank you all the faculty and all the delegates who have joined on this YouTube on this Sunday evening. Thank you very much.
Thank you. Thank you,
Thank
ma'am.
you, sir. Thank you very much, and
Thank
good
you,
night.
sir.
Thank you. Thiru,
Thank you.
Thiru,
Thank you.
any
Thank you.
comments, Thiru?
Dr. Singaravel.
Nothing much, sir, except that really enjoyed this kind of case-based discussions. Very rather than didactic lecture. Very thankful to both Dr. Lakshmi and Dr. Daisy for a very useful discussion, and I'm sure our people enjoyed. Actually, at the end of the day, it is about satisfying the objective. Our objective is to get different perspective, and we are really thankful that they went on a dialogue mode. So thank you very much, ma'am. I'm sorry my
Thank you, sir.
camera could not be turned because
That's
of
Thank
that.
okay.
you very
Thank you,
much.
Dr. Thiru.
Very much.
Thank you,
Thank
ma'am,
you.
and good night.
Thank you, all the
Thank you,
assistants.
sir. Thank you,
Mahadevan
sir.
sir,
Thank you,
please,
sir.
your words, sir. Oh, Mahadevan sir, please.
So, sir,
Yes,
a
sir.
very
Bye.
well defined algorithms from both Dr. Daisy and from Dr. Lakshmi. It's been wonderful to hear them. And I think repeated telling, especially on focus and other things, will definitely improve the entire scenario. Thank you very much, madam. Thank you very much,
Thank you,
Dr.
sir.
Garvin.
Thank you, sir. Thank you.
Thank you so much,
Thank you.
sir. Thank you,
Thank you, sir.
everyone.
Thank you.
Your presence will really make us really
Okay.
in spite of your
No, it's my
busy
pleasure,
schedule.
sir. It is my
Thank
pleasure,
you.
sir.
Thank you, sir. Thank you, madam. I'm happy that all
Thank you.
senior professors joined and both of you done extremely well. Thank you, our president, who's a visionary person who made all these things happen. Where this year, with full of academics, our Tamil Nadu is being full in swing of academics, and as Somsundaram Tirumurugan and told, every week you have different kinds of problems. Surely, madam, we will invite at one point of time physical meeting also to have your wonderful lectures.